Hi, my name is Erica Lewis, and I am going to moderate this wonderful session today. I'm going to go ahead and say it, name it and claim it. It's going to be a great session. We want it to be really interactive. We've got a panel of two wonderful speakers. And so what we will do is I will introduce the presenters. We'll have each presenter, they'll be presenting for about 15 minutes, and then we will spend the rest of our time, hopefully in a nice, robust, engaging conversation. Okay. Do we have any questions, comments, concerns before we begin? All right, so then let's get into it. So we have with us, we have Ashley Watson and Jessica Greenstone Weinstone. So Ashley she holds a master's in public health, and she's a doctoral candidate in the School of Public Health at Georgia State University. Her interests in research include maternal and child health, as well as substance use prevention among youth. Her dissertation project will focus on the impact of virtual delivery on home visiting implementation and outcomes. We also have Dr. Jessica Greenstone Weinstone. Dr. Weinstone is Principal Research Consultant at Jessica Greenstone Consulting. She uses qualitative research methods to examine the complexity of individual and interactional experiences among and between program participants and providers. Dr. Weinstone's work informs practices and policies to optimize participant access, engagement, and outcomes, as well as provider satisfaction and retention. So we will start with Ashley's presentation, which is entitled Virtual Delivery and Home Visiting, Insights from Administrative Survey and Focus Group Data. While Ashley is bringing her presentation up, I also wanted to remind folks that if you wanted to include your questions in the chat box, please do so. And then we will just go through them, and I'll ask you to just unmute yourself and present your question when it's time. Thank you.
Thank you so much, Dr. Lewis. Alrighty. Is that view okay for everyone? If I can just get a thumbs up. Oh, great. Thank you. Alrighty, as Dr. Lewis said, my name is Ashley Watson. I'll be presenting today on some research focusing on the Safe Care program, which I will also explain what that is, what that entails. My research colleagues include Dr. Lindsay Bullinger, Dr. Kelly Fong, and Dr. Shannon Self-Brown, who could not attend today. So the rationale for this study focuses around the COVID-19 pandemic. In March 2020, when this pandemic started, as many of you know, all of you know, we had stay-at-home orders and social distancing recommendations, which obviously impacted our work heavily as we work in home visiting programs. And the goal of the current study is to identify the changes in home visiting programs during that pandemic, using the Safe Care program as the focus. So the Safe Care program is an evidence-based skills training program for caregivers of children aged 0 to 5. It has three main components: parent-child interaction, safety, and health. And the mission is to ensure that young children have a nurturing, safe, healthy home environment through this training, implementation, support, and research. So the research questions for this mixed method study are: how does safe care implementation, fidelity, and outcomes vary during virtual delivery? Did virtual delivery of the Safe Care program impact provider fidelity scores? And what are safe care providers' perspectives on virtual delivery compared to traditional in-person delivery? So as you can see here, this was a mixed method study. We had three different data sources for research questions 1 and 2. We use the Safe Care portal data. This portal is where providers and trainers will submit all sorts of data regarding their families and the sessions that they provide. We use quantitative analysis to answer those questions. And for research question 3, those were primarily qualitative questions. And we used a survey of safe care providers and trainers, which occurred in June 2020, towards the beginning of the pandemic, and then some focus groups that followed up in fall of 2021. So the results for research questions 1 and 2 included the following. So there was no significant effect on the number of virtual home visiting sessions. No significant effect on the percent change of assessment scores. These are participant skill mastery scores, and no significant effect on client satisfaction scores. So this is all very positive. This is showing us that virtual delivery did not negatively or positively change those outcomes. So that means that we are still reaching the goals that we want, teaching those parents the skills that are needed, though we are delivering virtually. Also, we saw a reduction in the duration of program by 21 to 24 days. So that's as much as a 70% decrease in duration of the program, which I'll discuss why that is also very positive. And finally, the provider fidelity score analysis for research question number 2 is still ongoing. However, we did have some preliminary data that just came through yesterday. So this is hot off the presses. That it does look like fidelity scores were significantly impacted through virtual delivery when we controlled for various provider demographic and other factors. However, as I said, it's still preliminary, so you'll just have to wait for the paper to learn more about that. And so just to dive a little deeper into that, into those findings, the findings suggest that the program can be completed both quicker virtually, but without affecting these two graphs that focus on the duration of the program and percent change in assessment score. They were both equally satisfied with face-to-face and virtual delivery, which is great. And also to be noted, as I said, the duration was shorter, and some of the implications of that are that it might be able to save both time for our participants, make the program more appealing to those parents with less time. And finally, it could cut administrative costs in the long run. So that will be some of our future research directions. Moving on to research question 3 with our survey and focus group results. These were some of the qualitative themes that we found. Virtual delivery can increase service availability and efficient program completion. Virtual delivery can increase access to services for some groups, but others may be best served with traditional in-person services, and I'll discuss some of those groups in the next slides. And finally, service providers use creative adaptations to deliver the program virtually. So this is my personal favorite. I did lead the focus groups and I analyzed the survey analyses myself. So this is my favorite quote of the entire study. So one of our providers said, "We have each home visitor write up a little introduction letter, including a picture of themselves. This helps the families get to know a little more about each home visitor. The letter includes a little bit of personal info, such as their likes, educational information, and why they love home visiting and the Safe Care program. We also have an intake done via the phone that serves as an icebreaker for the family to begin building that rapport." So that was one really creative way that our trainers and providers were still able to connect with our participants, because we know that engagement and rapport is a key component of the success of the Safe Care program. So discussing some of those challenges, one of the quotes from our focus group was that families who live in an unsafe environment, such as a domestic violence situation, or simply don't feel comfortable having someone come into their home, perhaps for cultural reasons or health reasons. This may, as I said, this may be because of different disadvantages as well. The virtual delivery gives them that option to actually work with our program when before they would not have been able to. And a survey respondent said having reliable internet capability in rural areas has been a hurdle of remote delivery. So you can just see kind of the duality there, that yes, this is really positive for some individuals, but then it may make the program less available if you do live in an environment where internet capability is not as consistent. Also, when discussing some of those groups that may not be served as well with virtual delivery, we had a survey participant state that some clients had developmental disabilities, so they needed more help accessing services and resources. We also had some providers provide this feedback that clients with lower reading and other literacy skills, it was more difficult for them to receive things virtually. and they needed more of that in-person touch. Excuse me. So for our future directions, we believe that home visiting programs will need to adapt various components for successful virtual delivery. We had some different participants say we need hotspots, we need more virtual um, programming materials and things such as that, different 3D cameras. We got some really great feedback at our national center from these providers so that we can help give better service, which is always the goal. Also, additional supports, as I said, that could be physical as well as virtual. And we also noticed that many of them wanted more trainings, which have been developed to specifically address how do we deliver this program virtually. And finally, future research will investigate feedback and insights from program participants. As I stated, all of the qualitative data and even the portal data primarily focuses on providers and trainers, which is very important. Obviously, we want to support our staff as much as we can, but we would love to see from the side of the participants, aside from their satisfaction scores, just to dig a little deeper and see what they would like to see from virtual delivery if they see it as a positive way to move forward. And then finally, some of our conclusions are just that virtual or a hybrid service is a really promising direction for all home visiting programs, not just safe care, but that some program components and participants may not be as suitable for virtual delivery. Specifically for safe care, we saw that our safety module, which involves the provider coming into the home and looking at different aspects, taking notes, pointing out some different things we could do in the home to make it safer for the children, is far more difficult to conduct virtually. Sometimes some providers just found it impossible and opted to wait until they could go in person. So that's one example of how different program components can be more difficult virtually. I would love to thank our National Safe Care Training Center directors and team, the Doris Duke Charitable Foundation Research to Action Grant, which funded this research, our safe care providers and trainers who were so kind to take the time to participate in this research, as well as Georgia State and Georgia Tech. Thank you so much. If you have any questions, feel free to email me. And I would love to have any questions. Thank you so much.
Thanks, Ashley. We do have questions and we will be asking a little later, but we actually have a few minutes. So wanted to open it up to the group if there were any clarifying questions that you want to ask. Anything where if you don't get this information right now, you don't know what you'll do. You can't wait another 15 minutes. I have a quick clarifying question, which would be around the engagement strategies. Could you say more about the type of strategies that you use to engage the families
Of
virtually?
course.
Thanks.
Um, so, like I said, the introduction letter, that was my personal favorite strategy. But one thing we noticed when we conducted the focus groups, which was 3 separate focus groups of 9 providers total, and they were just selected across the country, but they started getting so excited together, collaborating, that they were like, oh yeah, we reached out to some providers in Oklahoma and they had this training video in Spanish. And so one of our providers in Wisconsin said, hey, can you share that with me? And so they were actually collaborating with each other, connecting after the focus group so that they could kind of not have to recreate the wheel.
Mhm.
So they were developing new, just like worksheets, training videos, things of that sort, and then sharing them amongst each other, which was amazing. Another engagement strategy I saw was without hurting fidelity, they would go in early. They'd give an extra 30 minutes just to kind of break the ice at the beginning of the session. And that gave them time to work with the participants, get to know them more, as well as work through any kind of Zoom or Teams technical issues. So that really helped with engagement a lot. I think, it's, of course, I said we'll have to talk to the participants, but I think it just showed how much their providers really care for them and their families, that they were willing to take the extra time to get to know them and to make sure that they could receive this program.
Thank you. So it sounds like a lot of resource sharing and relationship building.
Definitely. And we also had physical ones where we would have providers who live 2 hours from families drive there and do, I think they called them front yard hangouts or something. They would drop off all of their physical materials and stand at the edge of the lawn and talk to them to get to know them before the session started.
Wow, 2 hours. That's dedication. And that it seems
Yes,
like it made a difference. Great.
most definitely.
Thank you, Ashley.
Of course.
And so now we are going to turn to Dr. Weinstone's presentation, and it is entitled Individual and Program Level Drivers of Home Visitor Retention at Healthy Families, Massachusetts, a qualitative study.
Hi, everybody. I'm so happy to be here talking with you all today, and I enjoyed your presentation, Ashley. Looking forward to hearing any connections people might make afterwards. So, sorry, this is just not responding. Oh, there we go. Okay. So between the fiscal years 2019 and 2020, there was a 12% decrease in full-time home visitors at HFM. And the Children's Trust naturally wanted to investigate the causes of turnover and the potential of monetary incentives to improve staff retention. So I conducted a mixed method study in 2022, seen here as phase 1, and also called the Salary and Turnover Study. And that focused on individuals across HFM programs, including former home visitors and supervisors who had left their jobs, and current home visitors, some of whom reported the intent to leave. And that study identified salary dissatisfaction and documentation-related burnout as the primary drivers of turnover. So I'm currently conducting a phase 2 study to follow up and learn what makes staff members at HFM stay in their jobs. The primary aim of this study is to identify drivers of retention among HFM staff members. And the 2 ways that I'm going about doing that are to identify common characteristics of HFM programs that seem to be retention drivers, contributing to longer staff tenures at specific HFM programs that have retained most of their staff since 2019, including throughout the most challenging years of the COVID pandemic. And to identify individual staff member characteristics that seem to mitigate or counterbalance drivers of turnover, making some staff more inclined to stay than to leave. This is a qualitative phenomenological study, and I began coding at the question level for the program analysis and at the interview level for the individual analysis, using a purposeful sampling approach to recruit staff members and an iterative question guide, which allowed me to adjust the questions based on what I was learning from study participants, as well as to follow an individual home visitor's story. The thematic analysis that I conducted on both the program and individual levels involved identification of narrow themes related to intent to stay and intent to leave, and then the development of broader groupings across those themes. Once identifying the themes, I created these cross-case matrices to look for patterns across cases at either the program level or the individual level. For the larger study I'm conducting for the Children's Trust, I am including both long tenure and high turnover programs. But today I'm only presenting the findings from 4 of the long tenure programs. And as is typical of phenomenological studies, the sample sizes are small, at least to start with. So the program analysis I'll be presenting today includes 17 home visitors, and the individual analysis includes 8 home visitors. For the program level analysis, I was looking for what emerged through repetition across the questions you see here on the right. So what did staff say again and again were the reasons behind their desire and decisions to stay? And to be counted as a recurring theme, it had to be identified by home visitors multiple times across questions, as well as by multiple home visitors at each program site. So the questions were, why have you stayed and why have you continued to stay? Why is your program a good place for you to work? What about your job makes you feel satisfied or happy? What makes you feel you can be successful in your job? And why have staff tenures been long at your program compared to other programs from your point of view? So this figure shows the drivers of retention that emerged at the program level. Manager support, which is support of a professional nature, was identified by programs 1, 3, and 4 as a driver. And that could have been support from supervisors, program coordinators, who are directors. And it could have also been from both of those figures. Peer support qualified as a driver of retention only for program 1. And peer support means relying on other home visitors for work-related support, such as talking about cases to either brainstorm ideas or to debrief emotional reactions, as well as sharing resources and information that worked for other families. Work-life balance flexibility qualified as a driver for programs 1 and 3. And that refers to the ease of the process by which home visitors request time off to attend to a personal or family matter, and their ability to use flex time to make up hours missed due to those personal matters. There were 2 additional subtypes of flexibility that I identified in this study, but work-life balance flexibility is the only one that emerged as a retention driver. I did draw a distinction between support and relationships, and relationships include indicate a personal dimension apart from the personal relationship or support people get. So for peer relationships, which was a driver for programs 1, 3, and 4, this meant something that connects home visitors that is not just professional. So this could be a sense of closeness, having been supported when going through a personal experience that was difficult, knowing and sharing personal things about one another, or even connecting over a group text thread outside of work. In manager relationships, the personal element refers to home visitors noting that they have respect for who their managers are as people. So they have seen a personal side of them and the way that they interact with staff. They believe them to be caring. And in some cases, home visitors also talk about personal matters with them. Across all 4 programs, home visitors indicated that they are mission-driven, and this is a factor contributing to their desire to stay. And the theme that really arose repeatedly was that of being, rewarded when they watch families grow and succeed and when they're assisting families in doing that. Program 2 identified variety as a driver and was unique in doing that. And variety indicates that the job is not a cookie cutter one, that it looks different every day. Every visit with the family is unique. And they also enjoy being able to be out in the field rather than being limited to sitting in an office all the time. So programs 1, 3, and 4 each identified both program features and job features as drivers of retention. And each of these programs has at least 3 program features that rose to prominence. All 3 of these also identified manager support and peer relationships among the drivers. And programs 1 and 3 both noted the importance of flexibility to their retention. Program 2 stands apart from the others in that home visitors from this program only identified features of the job and no features of the program. I do want to note that where certain program qualities did not qualify as a driver, they may have been mentioned by some home visitors as being important to them. So for example, program 4 staff noted the importance of flexibility, but they didn't note it over and over again. So perhaps it's part of a well-rounded job experience for them, but not the primary factor keeping them there. So in this figure, I've excluded the job features, leaving only the program features, and added in some contextual factors. The caseload sizes and salary ranges vary across HFM programs based on the policies of lead implementing agencies. We can see that home visitor tenures are nearly the same between programs 1, 2, and 3, and higher at program 4. despite the variations in caseload size and salaries. Overall, it doesn't seem like home visitor caseload size or salary really helps to explain the variation that we see in the retention drivers, and especially the unique findings for program 2. So we do plan to look at additional contextual factors, such as the age of the home visitors at each program, the benefits offered by the lead implementing agencies, especially vacation time for staff with long tenures, and supervisor to home visitor ratios to see if these factors might help explain these findings. Another program level finding was that even though peer support was only identified by program 1 as a driver of retention and manager support was identified by 3 out of the 4 programs, home visitors in all 4 programs did feel that both types of support were accessible to them. And since I was asking here specifically about support, I excluded these questions and answers from the program level retention drivers analysis. So doing that coding at the program level led me to the decision to also pursue individual level analysis. There was variation that suggested that there might be individual factors influencing home visitors' experiences of their jobs. So for example, some home visitors reported being affected by work stressors frequently and outside of work, while others did not. So I first identified the broad categories of push and pull factors. And I categorized as push factors things that home visitors reported not liking about their jobs, having negative effects directly on them or on other aspects of their jobs, and generally leading them to dissatisfaction and kind of deterring retention. I identified as pull factors things that seem to promote retention, that home visitors talked about as having a positive quality, having positive effects on them or other aspects of the job, and generally leading to satisfaction, and things that would really make them feel hesitant to leave their jobs. And finally, I coded for how home visitors talk about job stressors and push factors. Are there ways of thinking, coping, or other personal qualities home visitors demonstrate that bolster their resilience to push factors and make them more inclined to stay than to leave? So through that individual level coding, I identified 4 ways that home visitors managed or adjusted to push factors, job stressors, and other features of the job that they were dissatisfied with. And I'm calling these individual adaptive strategies. So the first one is coping techniques. And that included things like having self-care practices that they use to manage work stress, as well as to separate work stress from life outside of work. Utilizing available supports within and outside of work, finding organizational systems that work for them to manage the workload and the variety of their job responsibilities, recognizing and accepting that they are not entirely in control of what happens in families' lives, maintaining a positive outlook, and reminding oneself of the ability to adjust to less than ideal circumstances. The next one is perspective taking, which includes being able to see things from more than one point of view and seeming to seek out the good side or give someone the benefit of the doubt. Also, compared with other home visitors, they seem to look at a challenging situation, kind of search for an explanation for it, and then accept that explanation. So for example, many home visitors talk about the burden of data collection, but those who used this strategy said that they understand how critical it is for research and funding, even though it does cause them additional stress. They see that point of view. The next strategy is self-efficacy, and that included home visitors who reported being drawn to challenges and feeling confident in their ability to handle them effectively, including the unpredictability of the home visiting role. And then believing that they're having an impact in families' lives and getting a sense of satisfaction from that. The final one is intent to stay, And this adaptive strategy had the smallest number of examples in the sample that I analyzed, but still seemed important to include. So for various reasons, these home visitors envision themselves staying in their job. And one reason is that some people don't like to change jobs. They kind of have a preference to stay in one place. Others reported that they don't think they could find certain features of their current job elsewhere, such as relationships with other home visitors or a sense of team. And, intent to stay is typically framed as an outcome, but in this case, it seemed to be used as an adaptive strategy. And those who indicated intent to stay did so in response to one of two questions. One was, what would make you hesitant to leave if you were considering leaving? And the other is, why have you stayed? So it does seem like an adaptive strategy, and obviously also is an outcome in many studies. So it seems like maybe they kind of made the decision about the outcome in advance, and maybe that makes them more tolerant of factors that create dissatisfaction. So 6 of the 8 home visitors in the individual analysis used a combination of these 4 types of strategies. 4 of the home visitors used all 4 strategies. And as you can see, they used quite a number of strategies for each home visitor. This is only the things that came up during the in-depth interview I conducted with them. And then half of these home visitors did indicate past or current intent to leave. One of these used none of the strategies. And I will say that that home visitor did seem to have plans to leave, not only intent to leave or thoughts about leaving. And one used one example of coping. Another used only coping and perspective taking. And one home visitor did use all 4 of the strategies. So I just wanted to give you an illustration of what these adaptive strategies look like when home visitors are using them. So 2 examples for each of the 4 strategies here. So for coping techniques, if I'm really struggling during the day, I would definitely call my supervisor. There's one family I meet and the mom deals with a lot of mental health struggles. So I usually put her at the end of the day and then breathe and move on because the workday is over. I try to space out my visits so I have time to process things or let go of things from one visit to the next if I need to. For self-efficacy, sometimes I hear something really difficult from a family and it's hard to process, but most of the time I think, what kinds of resources can I get for them? I'm drawn to the unpredictability of the job because it's a bit more of a challenge. My personality has always been like that. I don't mind working with difficult issues. For perspective taking, if my supervisor sends me an email or text and I'm reading into it, I'll call her so we can talk it out. A mismatch between us has been rare, and when it has been, it's because of the way I read the text or email. If a family is going through something I can't help with, and I know they're really struggling, we may brainstorm a lot and they don't follow through, so they're still stuck in that position. It's hard because sometimes we have the answers and it's easy for us to say, but the family is not ready. And finally, for intent to stay, to me, there wouldn't be another job like this. It's a good fit for me. It's a job I like. I look forward to it. I don't look forward to the sadness, but the job I enjoy. And finally, I don't like jumping around at jobs at all. I like to stay in a place. HFM has integrated the Erickson Institute's Facilitating Attuned Interactions model, also known as FAN, into their training. And the model is used by supervisors in their work with home visitors and by home visitors in their work with families. The model emphasizes cultivating awareness of one's own emotions and being mindful of how you react to them. And several components of the FAN model align with 3 of the individual adaptive strategies I observed home visitors using, as shown here. The clearest link is between collaborative exploration and perspective taking. I won't go into this in any further detail here, but I did want to point out that there is intentionality at HFM around fostering reflective capacity in home visitors. And that is likely to be one source of the adaptive strategies that home visitors in this study exhibited. I also want to note that this is a connection that was made after I had identified and categorized the individual adaptive strategies. Because the coding was inductive. So I was not intentionally looking for examples of the influence of FAN during this study. I'm
Dr.
pretty sure
Weinstein?
I'm short on time.
Yes,
Sorry.
so we have about a 1 minute, I would say 59 seconds.
Thank you.
No
Okay,
problem.
so I can come back to this slide if people are interested in how some of the concepts from this study do map onto concepts from 2 other studies. I just want to say quickly some of the findings that might provide some new insights. And I think overall, this research supports some of the goals of the precision paradigm. I think most notably trying to produce precise descriptions of what contributes to HFM home visitors' desires and decisions to stay in their jobs. And in that vein, using a qualitative approach, I identified features of HFM programs and the HFM home visitor role that might drive retention. The 3 subtypes of flexibility offered were also referenced by home visitors, and then the variety of job responsibilities, I believe, was a novel finding. And this study also led to the classification of individual cognitive tendencies of home visitors as a factor that might intervene in the influence of turnover drivers to promote retention, which might be thought of as a mechanism of action in the language of the precision paradigm. And 2 of the observed tendencies, perspective taking and intent to stay, I believe are new findings. I'm curious if people have seen them elsewhere. I don't have much time really to go over this, so I'll just kind of leave this slide up in terms of some potential future research directions, some of which I've mentioned and plan to actually look at myself as I continue this study because it is still in progress, and then some implications for practice, which I would love to discuss further. And I would also welcome connection and thoughts, suggestions, idea exchanges, etc. So you can reach me here. Thank you so much.
Thank you. And so what I'll do is I will start our conversation and our discussion. Tom, we have a little less than 15 minutes, but if folks, if you feel welcome, take yourself, you can show yourselves. Yeah, turn your camera on and we can start this discussion. You know, when I take a look and had a chance to really listen to the 2 presentations, there were 2 concepts that really held true for me that I thought were really important. One was engagement and the other was the importance of relationship building. And as I look at the HARC's, precision approach for home visiting, it really feels like there's a focus on trying to understand what works best for whom and how. And today's presentations really focus on 2 of those aspects. The what works best, which is the virtual delivery piece. Does it work better or as good as in person? As well as the how, which would be the engagement and the relationship building piece. So that's, relationship building between families and home visitors, as well as home visitors and organizational staff. And so I have a question for you, Dr. Weinstein. Given your study's findings and you highlighting the importance of peer support and relationship building, do you think that the relationship between home visitors and families may contribute to home visitor retention? And if so, how do you think that might be?
Thanks so much for that question, Erica. Yeah, I think, so I definitely did not look at that in this study, but I think, the mission-driven finding is a common denominator among the home visitors, every single home visitor in this study in the high retention programs. I would venture to guess the same will be true in the high turnover programs. But unfortunately, from the research I've conducted over the 2 phases so far, it just doesn't seem that on its own, it's enough to really sustain retention if there are active stressors, especially if workplace stressors are kind of seeping through the work-life boundary for home visitors. So, you know, there's a lot known about what enables good relationships to form between home visitors and families. And I think continuing to reinforce those concepts is certainly something that would be of benefit, because that is something that drives home visitors, the desire to want to connect with families and sort of do good by them, right? To really help them meet their own goals. So certainly continuing those practices will help, but I don't think that it's going to be enough without focusing on the workplace specific issues, workplace culture, possibly training some of these coping strategies or adaptive strategies, things like that.
So it couldn't work in silo, but it could be something that could work alongside other supports and services or trainings.
I think so.
Yeah, great, thank you. All right, I think the people want to talk, and so let's hear from folks. Please, we're going to utilize all the Zoom functions. So if you want to raise your hand, if you want to just take yourself off mute, please. Any questions or comments that you may have, please share.
I think I have a question for Ashley related to the virtual home visiting. I was wondering, and I may have missed it in the beginning, whether you saw a difference in terms of the number of home visits participants were receiving virtually versus in person for those who tended to stay in the program around the same length of time. Were you seeing any differences there? And then I was interested in hearing a little bit more about the thought around less duration in the program translating into more efficiencies that programs would see in relation to that. So, yeah, thank you.
Thank you so much for the question. So I would have to look back because I know some of our future research is going to focus on subgroups and more of that clustering, but that's a really excellent question. So I'll probably go analyze a cluster to say, like, if you were in the same duration, what were your sessions? I know overall there was not a reduction in sessions for virtual delivery versus in person, but that is a really great idea, and I'm going to make a note of it. So thank you for that. And your second question, I'm sorry, can you please remind me?
Sure, just more about the efficiencies that programs are anticipating they will see with participants staying in the program for a shorter amount of time. But you alluded to it in what you presented, that they'll be able to see the same amount of outcomes, maybe being able to serve more participants. I'm just curious as to the thought process around that.
Got it. Thank you so much. So I think some of the efficiencies, and these are just implications, we need to dig a little deeper, but I would think some of the efficiencies we're going to see is that we could serve more families, because it's going to be a shorter amount of time we spend with each family, like a shorter amount of days, not sessions or hours per se. I would also say I think that it would assist with administrative costs, since a lot of our programs are out of public health departments. And so their staff has to be trained in our programs. It takes a lot of time, but obviously it's very beneficial for our families. And they have very large caseloads. So I think that will help us reach more families while, also dealing with kind of like Jessica's presentation was saying, some of that lack of retention and staff shortages we've just been experiencing because of COVID. I think another thing is that it'll make the program more appealing, because traditionally our providers will go into a home for 2 hours a week, but it's all in one session, which can be very long for working families. especially single parents. And so I think this is really appealing that they have this virtual hybrid option, but also to say, okay, it's virtual hybrid and it's not going to take up quite as many months of your life potentially.
Thank,
So I think that's some of the efficiencies.
thank you, Ashley.
Oh,
We've got, yeah, the chat is just moving and shaking. So we're going to move along to the next question, which was from Quintella. It was around the diversity and years of experience for providers or home visitors. So there was a question about that. And this is for both studies. So maybe we'll start with Dr. Weinstone. Can you tell us a bit more about that?
I'm sorry, can you repeat the question?
Sure. So Quintella was wanting to know more about, I'm believing race and ethnicity as far as the diversity of the home visitors, as well as the years of experience. So thinking about the different agencies or programs that you looked at, what was the makeup?
Yeah. So because the sample sizes were so small, I mean, each home visiting staff program, each home visiting staff was between 3 and 5 home visitors at each program. So I didn't look at demographic information as of yet, at least, as a factor that may have really played into this picture. And as far as years of experience, so the criteria for inclusion in the study was having at least 5 years or among most of the home visitors at a particular program. So it could be that there was one example of turnover and then, you know, there was a new home visitor there, but for the most part, the home visitors had worked at least 5 years, and at all of the programs, home visitors worked, there were home visitors that had been there between 8 and 23 years. So certainly a lot of years of experience. And I do think that it's possible that where people are in their career trajectories will drive, and also in their personal lives will be a part of what influences what is driving them and motivating them to stay or to move on, and what they're really looking for in a workplace experience. And so that is something that I do plan to look at to find out if there's other demographic characteristics that might be influencing, you know, why people are valuing work-life balance, flexibility, which might be more relevant or pressing to some people than to others, depending on the stage of life and their family makeup.
Thank you. And we have about 3 more minutes. Ashley, I know that so we have a list of questions, which what we'll try to do is send them out to the presenters so that they can answer them. And so I think we have time for one last question before we move along. And Ashley, this is going to be for you. This is from Shirley. And so it was a question regarding the virtual home visiting. They wanted to know a bit more about the modes and methods that you use for the virtual engagement piece.
about the modes and methods for virtual engagement. So, what I saw from our providers, as I mentioned before Dr. Weinstone's presentation, was they tried to do a lot of icebreakers, getting, you know, rapport building conversations outside of the sessions, a lot of the times before the session, such as sending text messages, emails, physical letters, doing those front yard meet and greets. Another one that I saw that was very common was sending text messages and doing like check-in phone calls more frequently in between sessions. And those, it was a toss-up. Some providers, it wouldn't even be about sessions or anything, just how are you doing? How are your families? How can we help you? What resources can we connect you to? And there was a lot of really positive feedback about that.
Thank you.